Yes, my dear students, let me welcome to you all to this lecture class on behalf of the Department of Surgery. You know, the college authority has decided to take the classes of the students to involve you in the academic activities from 9 to 2. By this time we have given you the class routine. I like to give thanks to college authorities, especially the principal and director, and Professor Musalin, Dr. Liju, Dr. Khaled, and the IT department of our medical college. They took trouble to attend these classes. You know, we like to start the class as usual with the Zoom, but we had some problem in the Zoom, especially the audio problem. In Zoom, I think that is interactive. If I wish, I can see your faces, but in Facebook Live, it is the one-way discussion. Even then, I think you will be benefited with this discussion. And you know, these are actually a brief outline of the lecture classes. It is not the total thing. We will give a brief guideline so that you can go through the text, you can go through the journals, you can go through the internet, and you can take preparation for the exam. So today, we would like to start a topic of colorectal surgery, that is, we will discuss carcinoma of the rectum. So I request you listen very carefully, and if necessary you can take the notes so that during exam you can revise the situation. Regarding the carcinoma of rectum, it is overall colorectal cancer is the second most common malignancy in Western countries, with approximately 18,000 patients dying per annum in the UK. And among the colorectal cancer, the rectum is the most frequent site involved. So this is a very important point to be noted. Amongst the colorectal cancer, rectum is the commonest site. Let us discuss how it originates. It is now accepted that the colorectal cancer arises from the adenoma in a stepwise progression, in which increasing dysplasia in the adenoma is due to accumulation of genetic abnormalities. This theory we call adenoma carcinoma sequence. The theory states that initially there is the formation of adenoma, and by a multiple complex process, there are some carcinogen, there are procarcinogens, all these acts together, ultimately the adenoma is converted into a carcinoma. And we all know what is a carcinoma. It is a malignant tumor arising from the epithelial origin. And nomenclatures, according to the type of epithelium it arises. So for example, if it arises from the squamous cell, we call it squamous cell carcinoma. If it is arises from the gland, then we call it is the adenocarcinoma, like that. And what is in counterpart is the sarcoma. This is the malignant tumor arising from the mucin, that is connective tissue. So again, this is a very basic question we usually ask in the examination: what is in carcinoma and what is in sarcoma? And there are some differences between carcinoma and sarcoma. It is well taught in the pathology lecture, so you must be very careful regarding what is the difference between carcinoma and sarcoma. In approximately 5% of the cases, there is more than one carcinoma in presence. This is we call the synchronous cancer or synchronous malignancy. Again, this is very important questions in the examinations. There are actually two terms. One is synchronous and another is metachronous. So you must be very careful regarding these two terms, which is synchronous and which is metachronous. The synchronous means if the primary malignancy present at the same time with different site. Say for example, the patient is having a carcinoma in the rectum as well as in the ascending colon. In this case, it will be nomenclatures, or it will be termed as synchronous. And what is metachronous? Metachronous means that if the tumor arises after a particular period after surgery. Say for example, a patient has undergone a surgery for carcinoma rectum. If the patient subsequently develops malignancy in other parts of the colon, then it is called metachronous. So I think these two terms should be very clear, what is a synchronous and what is a metachronous. If you look at the gross type or macroscopic type of the malignancies. There are 4 common types. It's common to all part of the large gut. That is, it may be ulcerative, it may be cauliflower, it may be annular or tubular. Ulcerative means it will present like a malignant ulcer. Cauliflower means it is a proliferative lesions. Annular means it is a stenosing type. Tubular means if the stenos segment is the long one, then we term it as a tubular one. So these are the 4 types of macroscopic type of carcinoma of the colon or carcinoma of the rectum. Another very important thing is how carcinoma spreads. So it is very common question in the exam, how the malignant tumor or a particular type of malignant tumor spreads. We are here talking about the carcinoma of the rectum. So if we think of local spread, the local spread occurs circumferentially rather than in a longitudinal direction. This is very important. The local spreads occur circumferentially. It is thought that a period of 6 months is required for the involvement of the quarter of the circumference, and 18 months, 2 years for the complete encirclement. So if you find a malignant tumor is a whole occupying the whole circumference, so from here we can predict the tumor is minimum 18 months to 2 years of age. After the muscle coat has been penetrated, the growth spreads into the surrounding mesorectum, but is initially limited to the mesorectal fascia. This is another very important things in the carcinoma of the rectums. Behind the rectum there is a loose tissue which we call mesorectum. So all the lymphatics are situated in the mesorectum, but for a particular period of time the malignant tissues are found in the mesorectal tissue or mesorectal fascia. After a certain period, then the tumor spreads distally. If penetration occurs anteriorly, the prostate, seminal glands and urinary bladder becomes involved in case of male, and in female the vagina or uterus may be involved anteriorly. In either sex, the penetration, if it is lateral, the ureter will be involved. So this is a very important part of the patients regarding its morbidity and mortality. You know, if ureter is involved, so that patient may develop obstructive uropathy or renal failures. With posterior penetration, it may reach to the sacrum and sacral plexus. So if the tumor goes posteriorly to the sacrum and the sacral plexus, if the sacral plexus is involved, pain. So if a carcinoma of rectum patients develop severe pain, especially posteriorly, so we may thought that the patient has involved the sacral plexus. Regarding lymphatic spread, the lymphatic spread from the carcinoma of the rectum above the peritoneal reflections occurs almost exclusively in the upward direction. So all the lymphatic spread will be in the upward direction. Below the level of the peritoneal, the lymphatic spread is still upwards, but when the neoplasm lies in the field of middle rectal artery, primary lateral spread along the lymphatics that is not infrequent. So mostly upwards, but lateral infiltration may occur. A radical operation should ensure the high-lying lymph nodes are removed by ligating the at a higher level. Atypical and widespread lymphatic permeation can occur in highly undifferentiated neoplasms. So this is the typical mode of lymphatic spread. It's very important. Regarding the venous spread, the principal sites of blood-borne metastasis are liver 34%, lungs 22%, and adrenal glands 11%. The remaining 33% are divided among the many other locations where secondary carcinoma deposit may trend to loss, including the brain. Another important thing is the peritoneal dissemination. This may follow penetration of the rectal carcinoma. Now the staging, this is very important. You know, in treating a malignant tumor, it is common to all. There are basically 3 principles of treating. Number 1, you confirm diagnosis. Number 2, you do the proper staging. And number 3, treatment according to the stage. And this is common in all malignancies. So you must remember that there is 3 formula of treating a malignant tumor. First of all, you have to confirm your diagnosis. Second of all, you have to do a staging if possible, and the treatment will depend upon Here, the commonly used thing is the Duke's classification of carcinoma of the rectum. So what it states in Duke staging: stage A, stage B, and stage C. In stage A, the growth is limited to the rectal wall. You will get it in 15% of the cases. Here, the prognosis is excellent. In Duke stage A, we are telling that the growth is still limited to the rectal wall, and naturally the prognosis is very good or excellent. Stage B, what is the growth is extended to the extrarectal tissue, but no metastasis to the regional lymph nodes. In 35% of the cases, you may get the Duke stage B. Prognosis is reasonable here. So what is happening in stage B? The growth is extended to the extrarectal tissue, but no metastasis to the regional lymph nodes. And in stage 3, there are secondary deposit to the regional lymph node. So here you can find if the tumor goes to the regional lymph nodes, then it is stage 3. Again, stage 3 is divided into C1 and C2. What is C1? In which the local pararectal lymph nodes alone are involved, and in C2, in which there are lymph nodes accompanying the supplying blood vessels are implicated up to the point of division. So this is very, very important. You have to memorize. Often in the exam, the examinees or students are staging methods used in case of colorectal malignancy. So you have to say, sir, you are used Duke staging use. There are 3 stages: stage A, stage B, and stage 3, C, and again C is into C1 and C2. So this is very, very important. There are another methods of staging is very common staging is the TNM staging, that is tumor, nodes, and metastasis. It is almost one of the universal staging methods. In many cases, TNM staging is possible. T stands for tumor, and N stands for lymph node, and M stands for metastasis. So T is again divided into T1, T2, T3, and T4. What we mean by T1, tumor invasion through the muscularis mucosa, but not into the muscularis propria. What we mean by T2 is the invasion into but not through the muscularis propria. What is T3? T3 means tumor invasions through the muscularis propria but not through the serosa. And T4, when the tumor invasions through the serosa or the mesorectal fascia. Here again, important things to notice. T4 means involvement of the serosa. So if you say the tumor is T4, by this time we means the tumor has already involved the serous layer. Regarding the node, N describes the nodal involvement. N0 means no lymph node involvement. N1 means 1 to 3 lymph nodes involvement. N2 means 4 or more lymph nodes involved. So if we say there is N0 means no nodal involvement, and M indicates the presence of distance metastasis. M0 means no distance metastasis, and M1 means distance metastasis present. So you can classify or stage the carcinoma rectum in the TNM staging also. Now another important thing is the histological grading. Again, this is a very important question asked in the examination, and you have to understand what we mean by the grading. By grading, we means histological, that is the histological differentiations. There are low grade, there are that is more well differentiated, moderately differentiated, and anaplastic. So there are these staging. What is the importance of this staging? This staging is very important as it is very much involved for the prognosis of the patients. Say for example, a low grade that is well differentiated, the prognosis is good. Average grade, that is prognosis is cases may occur, prognosis is very poor. Vascular and perineural invasions are poor prognostic features in the primary mucoid carcinoma, and this is very, very bad type of tumor if there is a mucoid type. The mucus lies within the cells, displacing the nucleus to the periphery, and like the seal of a signet rings. You have taught in the pathology, we call it the signet ring appearance. So by clinical things, we can tell that if it is a mucoid type, the prognosis is really, really very, very poor. Again, this histological staging will tell us the modalities of treatment. How we will treat the patient, it will depend upon the staging and the grading as well as. So now the clinical things, what are the clinical features? It's very important. Clinical carcinoma of the rectum occurs earlier in the life, but the age of the presentation is usually above the 55 years when the incidence rises rapidly. So it is a disease of the elderly, but nowadays we are getting many patients under 35 or under 30. The patients are suffering from carcinoma of the rectum. Often the early symptoms are no insignificant that the patient does not seek advice for 6 months or more, and the diagnosis is often delayed in younger patients as these symptoms are attributed to benign causes. The important thing is that initially the symptoms may be very similar to that of any other disease of the rectum and anal canal. So in young patient usually the symptoms are not taken in account very seriously and it misses. And another important thing is that if a patient with this type of symptoms go to a general physician, actually they see the patient and take the history, but they usually do not do the pararectal digital examinations, and that's why most of the cases diagnoses are often as very delayed. If a initial physician or surgeons do not do a digital rectal examination, often the patient will not come to the surgeon very early stages. When he reports to the surgeon, then it is already too late. So it is a very, very important thing. If any doctor find a patient with bleeding pararectum or alteration of bowel habit or slight pain or discomfort, feeling of incomplete evacuations, the minimum that is physical examination is to do a digital rectal examination. Otherwise, the diagnosis will be missed. The clinical features usually present like bleeding. The bleeding is the earliest and most common symptoms. There is nothing characteristics about the time at which it occurs, nor the color or the amount of the blood. Often the bleeding is slight in amount and occurs at the end of the defecations, or it is noticed because it is stained the underclothings. Indeed, more often than not, the bleeding in every respect simulates that of the internal hemorrhoids. So that is very important. If the patient came with you and the physicians or surgeon with pararectal bleeding, the bleeding of malignant lesion is not very characteristic. So it may mimic the bleeding of the hemorrhoids. Another important point is there, the hemorrhoids and carcinoma sometimes coexist. In elderly patients, the patient is having a malignancy as well as the patient is having a hemorrhoids. So this is a symptomatic hemorrhoid. Another important point is the sense of incomplete defecations. So these things should be taken in account very seriously. If the patient is complaining of sense of incomplete defecations, so that is very, very, very significant. The patient's bowels open, but there is sensation that there is more feces to be passed. There is a term we call tenesmus, is a distress straining to empty the bowels without resultant evacuation. That is, the patient have urge to defecate. Patient will go to the washroom or toilet, but there will be desire and patient will strain, but at the end there will be no stool. So this is called tenesmus, that is painful. And sense of incomplete evacuation means that is the patient will feel after defecation, patient will again go to the toilet or washroom. This is very important and early symptoms, and is almost invariably present in the tumor of the lower half of the rectum. The patient may endeavor to empty the rectum several times a day. This is again, there is a term which is called spurious diarrhea, often with the passage of flatus and a little blood stained mucus, that is bloody slime. So if a patient complains to you, the patient is a sense of incomplete evacuation, you should take it very seriously. These type of symptoms you cannot ignore. So if the patient develops a sense of incomplete evacuation, and what is the pathology of this sense of incomplete evacuation is that if there is a mass in the rectum feel that there is stool. So there is a reflex and the patient wants to clear the rectum. But this is not the stool, this is a fixed tumor. So continuously it will irritate the rectum and the patient will develop a reflex. That is, these things we call the sense of incomplete defecation or evacuation. If you find a patient is complaining of sense of incomplete defecation or evacuation, these things should be taken very seriously. You should do the thorough physical examination, including DRE, and if necessary, you do the further investigation that will be discussed later on. Another important clinical feature is the alteration of the bowel habit. This is the next most frequent symptom. The patients may find it is necessary to taking an apprehension or to supplement the usual dose. The patient who has to get up early in order to defecate, or who passes blood and mucus in addition to the feces. That is, again, is called early morning diarrhea. It is usually found to be suffering from the carcinoma of the rectum. So, what is alteration of bowel habit? Say, for example, a patient has a regular habit of passing stool once in the morning. Suddenly, patient develops that this rhythm has been changed. And again, if the patient is complaining of diarrhea and patient few days diarrhea and few days constipation, again we call this the alteration of the bowel habit. So if the patient is the patient is needed to increase the dose of the laxative to clear the bowel. So these three things together we call the alteration of bowel habit. So if a patient complain a alteration of the bowel habit, so this is very, very important symptom. Again, you should not take it very lightly. You should take it account very seriously, and you should examine and you should investigate the patients as early as possible. Another complaint or symptom is the pain, and in case of malignancy all over the body, the pain is the late symptom, but pain of colicky character may accompany advanced tumors of the rectosigmoid junction, and it is caused by some degree of intestinal obstruction. So what is the cause of pain here? Because if the tumor is of tubular or annular variety, it may cause a type of intestinal obstruction. So the patient will develop say colicky pain. When a deep carcinomatous ulcer of the rectum erodes the prostate or bladder, and there may be severe pain in the back, or a patient pain like sciatica occurs when the cancer invades the sacral plexus. So actually there are two types of pain. One is colicky pain that will occur in annular or tubular variety, and if the patient is having a constant pain, severe type of pain, it indicates the involvement of the sacral plexus posteriorly. Weight loss is suggestive of hepatic metastasis. So if in all malignancies there is actually weight loss. In case of carcinoma of the rectum or carcinoma of the colon, the extra thing is that if the patients had liver metastasis, hepatic metastasis, there is rapid weight loss in case of carcinoma of the colon or carcinoma of the rectum. Now the physical examinations is very, very important. Apart from the general examination, actually the physical examination has two parts: the general examination and the local examinations. So in the general examination, you will have to see the condition of the patient nutritional status. Patients, you will have to see the anemia of the patients. You will see if the patient is jaundice or not. So everything you should look for physical examination. One of the important things is the patient in malignant patient. If it is the advanced one, patient may be cachectic. That is extreme weight loss. Patient may have tricep skin fold thickness very less. Patient have a mid-arm circumference below a standard level. Patient, there may be changes in the tongue. These are due to all malnutrition and vitamin deficiencies. So you have to examine the patient thoroughly in physical examination as well as that is in general examination. You should not omit the general examination in the physical examinations. Apart from the general examination, you have to do a thorough abdominal examination. Abdominal examination is normal in early cases. It's very, very important thing. In early cases, you'll not find any abnormalities in the abdominal examinations. When an advanced annular tumor is seen in junctions, signs of obstruction of the large gut. At the time the patient seeks advice, metastasis in the liver may be palpable. If it is an advanced case, you may find the liver is palpable. That is the patient has already developed. When the peritoneum has become started with secondary deposit, as may result. So in the ascites, there are two tests to determine the ascites. One is the shifting dullness and another is the fluid theory. So it is commonly asked in the examination how you will ascertain the patient is having ascites. So you have to say, sir, I will do a shifting dullness or fluid thrill to ascertain whether there is ascites fluid cavity or not. Now the important thing is the digital rectal examinations, rectal examination or digital rectal. Nowadays we call DRE, examination. You know, it's the carcinoma of the rectum. The length of the rectum is 12 centimeter, and we divide the rectum 3 parts: upper, middle, and lower part. So if it is a 12 centimeter, that is 4 centimeter in each. So we divide the rectum in upper rectum, mid rectum, and lower rectum. So the rationality of the digital rectal examinations, we find out the location of the tumor, where it is located, and to determine the type of the, and to see the extension of the tumor. So that is our examinations. So it will depend, our findings will depend on the types. If it is ulcerative one, you will find the rectal examination, you will find ulcerative of. So what is the criteria of the malignant ulcer? The liver edges of the ulcer will be raised and everted, and the base will be indurated. So it is a very important thing. The edges will be everted and the base will be indurated. If you find an ulcerative lesion, you will find that there is a big ulcerative lesion inside the rectum. If it is a stenular, annular, or tubular lesion, you will find that your finger is very difficult to pass to the lesion. There is an option of manual examinations. It may be possible to feel the lower extremity of the carcinoma situated at the rectus segment junctions. After the finger has been withdrawn, again an important point, after digital rectal examination, if the finger has been withdrawn, it has been in direct contact with the carcinoma, it is smeared with the blood or mucopurulal material tinged with the blood. So after digital rectal examination, it is important to see or to examine your finger. In case of malignant lesion, usually you will find that mucus and blood has been stained with the finger. And in females, a vaginal examination should be performed, and when the neoplasm is situated on the anterior wall of the rectum, with one finger in the vagina and another finger in the rectum, is very accurate palpation may be carried. So in the local examination, this digital rectal examination or pararectal examination is very, very important. And you know, the normal position of the pararectal examination or DRE is the left lateral position. And in the examination, it is commonly, in the Viva board, it is commonly asked how you will do a digital rectal examination, what are the things you needed for digital examination, what are the position, and what are the procedure of doing a digital rectal examination. So you have to learn these few points about the digital rectal examinations. Then the proctosigmoidoscopy is very, very important for the diagnosis. Proctosigmoidoscopy always shows a carcinoma present provided the rectum is empty of feces beforehand. So before doing this proctoscopy or sigmoidoscopy, the rectum should be very clear. So if it is it is full with stool, you cannot see or you cannot assess the patients properly. In that case, the patient is advised to give a enema simplex so that the rectum is open. So procto means rectum and sigmoid means sigmoidoscopy. By proctosigmoidoscopy means examination of the rectum and the sigmoid colon. Now the most important thing is to take the biopsy. So as I stated initially, we have 3 principles: confirmation of the diagnosis, and do staging and treatment according to the stage. So our first step is to take a biopsy. Using a biopsy forceps, by a sigmoidoscope or a proctoscope, you can take a tumor for histopathological examination. So if you find an ulcer, it is advisable to take multiple biopsy, or if you find an ulcerative lesion or a cauliflower lesion, it is better to take multiple biopsy, because in a single biopsy the tissue representatives may not be come out. So it is better to take multiple biopsy, that is biopsy from the multiple site. And biopsy is the procedure done by the surgeons, and histopathology is the procedure that is done by our histopathologist colleagues. So biopsy is done by the surgeon, and histopathologist, that is histopathology is done by our histopathology colleague, the pathology colleague. So by taking a biopsy, our first step, that is a confirmation of the diagnosis. Then a colonoscopy. A colonoscopy is required in all patients to exclude the synchronous lesion. As I stated or discussed in the early in my lecture, so there may be synchronous tumor. So if there is a synchronous tumor, your treatment modalities might, that is the operative procedure might be changed. So say for example, a patient is having a carcinoma of the rectum as well as the carcinoma of the ascending colon. This condition is called synchronous. So to exclude the synchronous malignancy, all patients should be examined by this colonoscopy. If a proximal adenoma is found, it can be conveniently snared with the removable biochar. So colonoscopy has got other options as well as it is both diagnostic and sometimes it is therapeutic as well as. Say for example, the patient is having a carcinoma rectum, and you found is an adenoma type lesion in the colon. So during colonoscopy, you can excise that proximal adenoma if you found in the colonoscopy. So if a synchronous carcinoma is present, the operative strategy will need changing. That is the most important thing. So if you are asked in the examinations why you would like to do a colonoscopy, then you will have to say, sir, I will go for a synchronous carcinoma if present. What will be the consequence of finding a synchronous carcinoma? If we find a synchronous carcinoma, then the treatment strategy, especially the operative treatment strategy, might be changing. Now, what is differential diagnosis? So when an adenoma shows evidence of induration of unusual friability, it's almost certain that malignancy is invaluable in distinguishing carcinoma from an inflammatory stricture or amoebic adenoma. So these are the differential diagnosis. Adenoma, so there may be that is a benign lesion, adenoma. There may be stricture in post-inflammatory or due to amoebic granuloma, and the possibility of a carcinoid tumor in atypical cases must be. So carcinoid tumor is another, and again a differential diagnosis. So the differential diagnoses are adenoma, strictures, post-inflammatory stricture or amoebic granuloma, and carcinoid tumor. Regarding treatment, actually some form of excision of the rectum is essential, if at all possible, because the extreme suffering, it is necessary to assess. Before going to a surgical procedure, it is very important to assess the fitness of the patients for operation. You have to see, you have to look whether the patient is fit for the operation or not. The extent of the spread of the tumor, that is the staging, that should be done before operation. The extent of the spread of the tumor, that is called staging. The findings will affect the surgical approach. The assessment of the spread include liver and chest radiograph. You can go for PET, that is position emission tomography, can be helpful in identifying metastasis if imaging and otherwise is equivalent. So basic treatment is the excision. So that is in excision of a benign tumor and excision of malignant tumor is a little bit different. In benign tumor, you can just inoculate, or simple excision is possible or is enough. But for a treatment of a malignant tumor, the excision with a clear margin. So that is very important, and that is very, very important to do a wide excision minimum in case of any malignant lesion. If you are treating a malignant lesion, a simple excision is not enough. Minimum is the wide excision, that is a wide margins of the tumor. A healthy margin should be taken with the tumor as well as. And another is radical excision. What do you mean by radical excision? Radical excision means the excision of the tumor, clear margin with all lymphovascular territory. If you can excise and block the tumor with a clear margin and the lymphovascular territories, then we call it as a radical excision. And usually radical excision is the curative for a malignant lesion. What are the other modalities to assess the patient? you can assess the patient with endoluminal ultrasound. What is that? This is then again an ultrasound where a probe is placed in the rectal lumen and can be used to assess the local spread of the tumor and particularly accurate in staging the degree of penetration to the rectal wall in early tumors. As we rectal carcinoma, usually there is spread is the circumferential one. So how much it spreads, either it spreads through mucosa or muscle or pararectal tissue or serosa. So that can be this endoluminal. What is the advantage of ultrasound? There is no contraindication and it is very easy to done. There is no contraindication. So these are the advantages of doing an endoluminal ultrasound. Regarding the CT scan, a CT scan is not particularly accurate in local staging in carcinoma, rectum especially, which is better performed by MRI. So in case of staging of the carcinoma of the rectum, the MRI is more important than the CT scan. But if there is no MRI then CT scan is okay. So either by doing a CT scan or MRI, we will see the circumferential growth. That is, again, the tumor is situated in the wall, situated in the muscle, or it invades the pararectal tissue, or how much it involves the mesorectum. That can be clearly determined or assessed by doing an MRI scan or a CT scan. Here in this picture, you can see a picture of endoluminal ultrasound, and you see clearly in this wall, you see in this wall there is involvement of the mucosa, submucosa, muscle, and it goes beyond the pararectal tissue. So that is of course this is a T, that is involves the pararectal tissue. Now the principles of surgical treatment. In all treatment or all surgical procedure, there is basic principles. The radical excision of the rectum together with the mesorectum and associated lymph nodes should be the aim. So as I stated earlier, our aim is to do a radical excision. What we mean by radical excision? The excision of the tumor and the safety margin together with the mesorectum. And in this area, all the lymphatics are situated. So we will do a radical excision together with the excision of the mesorectum. Even in the presence of widespread metastasis, a rectal excision should be considered. So there is again an important thing. Say for example, a patient is having a widespread metastasis in the liver or peritoneal cavity. Even if possible, we try to excise the lesion. That is our main. That is, it is not a radical one. It is a palliation, but it is the best palliation if some form of excision of the tumor can be possible. The presence of liver metastasis does not necessarily rule out the feasibility of a rectal excision. Say for example, if the patient is single metastasis in the liver, radical excision may be possible. But if there is a widespread involvement of the liver, extensive liver metastasis, that is, in that case, the radical excision is not usually done. Then we go for the palliative treatment. When a tumor appears to be locally advanced, that is invading an innervative structure or treating to breach the circumferential resectal margin, the administration of a course of preoperative chemoradiotherapy may reduce the size and make the curative surgery possible. The thing is that this is a technique we call down staging of the tumor. Say for example, a tumor is in the T3, so by giving this neoadjuvant therapy, it may be possible to come to the tumor, take to the tumor in T2. From T3 you can down stage it to T2 or T1. So this is called neoadjuvant therapy. You know, in radiotherapy there are two modalities of therapy. One is adjuvant and another is neoadjuvant. Neoadjuvant means if it is applied or given before the surgery, that we call the neoadjuvant therapy. And if chemotherapy or radiotherapy is given after the surgery, that is called adjuvant therapy. Again, this is a very important, tricky question in the examination. We may ask the students, what do you mean by neoadjuvant therapy, or what do you mean by adjuvant therapy? Recent evidence suggests that the administration of preoperative short course neoadjuvant therapy in resectable rectal cancer causes significantly reduced incidence of local recurrence. So that is another important issue to be discussed. After the surgery in case of carcinoma of the rectum, another important issue is the local recurrence. it is seen often 6 months after surgery or 1 year after surgery, the patient develop local recurrence, that is in the tumor bed, in the mesorectum. So that is a very, very important complications of it, that is the surgery. After doing the surgery, the patient may come to you with the local recurrence. So here evidence suggests that if you give a preoperative, that is neoadjuvant short course therapy, radiotherapy, so it reduces the incidence of the local recurrence. When a rectal excision is possible, whenever feasible, the aim should be to restore the gastrointestinal continuity and continence by preserving the anal sphincter. So you have to understand that what is our aim. Our aim is, after excision of the tumor with the resectable margin with the mesorectum, to restore the gastrointestinal continuity. So you have to, it's better to, if you possible, to restore the gastrointestinal continuity and continence by preserving the anal sphincter. It's very, very important to keep the sphincters intact. Because if the sphincters are destroyed by the tumor or surgery, the patient will develop fecal incontinence, and that is not acceptable by the patients, that is not acceptable by the attendants or family. So it is very, very a problem. So that we have few options operation. The name of this operation is called anterior resection. It's a very it's a misnomer because it is not only done in the anteriorly, but it is circumferentially done. Even the name of the operation is lower margin is 2 or more centimeter above the anal canal. So after excision of the tumor, if there is clear margins of 2 centimeter or more, in that case, that is a sphincter saving operation, or that is anterior resection is possible. Although the removal of the rectum with the permanent colostomy, another option is the abdominoperineal excision. This is in this procedure, the removal of the rectum and with a permanent colostomy. So you have two options: a sphincter saving operation or anterior resection, where the tumor is situated a little bit upper position. It is possible to maintain the anatomical continuity and as well as to save the sphincter. And if the tumor is located in the mid rectum and the lower rectum, a safety margin of stoma, clear margin is not possible, then you have to sacrifice the anus and the sphincters. And in that case, the patient will need a permanent pelvic colostomy for lifelong. Nowadays, we have the modern technological things has been introducing into the medical science, especially in the surgical field. Nowadays, we are using the stapling gun. I think you have seen in the operation theaters, there are different type of stapling guns are used by the surgeons. There are circular stapler, there are linear stapler, linear cutter, or something like that. So these, by the use of this stapling gun, it is possible to do a safe anastomosis in the pelvic cavity, where hand stitching is not possible sometimes, because the pelvis is a very narrow region, and by hand swing anastomosis, sometimes there is less space and it's not possible. But if you use the stapling gun, it is so these are disposable, these are costly, and by using this stapling gun, sometimes anatomical continuity can be maintained. Again, the principle of operation involves radical excision of the neoplasm, removal of the mesorectum, that is total mesorectal excision, we call TME, removal of the total mesorectum with high proximal ligation of the inferior mesenteric lymphovascular pedicle. So these are the main principles of the operation. That is, you will have to radically excise the neoplasm with a safety clear margin, total removal of the mesorectum, and high proximal ligation of the inferior mesenteric lymphovascular pedicle before handling the tumor. Once rectum has been adequately mobilized, it is removed and the rectal stump is washed out. Restoration of the continuity by direct end-to-end anastomosis, either by manually or by stapling, must be carried out by meticulous technique to reduce the risk of suture line breakdown. So this is anterior resection, that is after excision of the rectum, after excision of the mesorectum, anatomical continuity either by manual or by stapling. This is called anterior resection. And if you excise the rectum and you sacrifice the sphincter and do a permanent pelvic colostomy in the left iliac fossa, this is called a abdominoperineal resection. And in this operation, two group of surgeons, one from the abdominal side and another from the perineal side, works together. So what are the preoperative preparations? Sometimes mechanical bowel preparation is necessary. Another very important is the counseling and sighting of the stoma. So counseling in these cases, group of the patient is very, very important. You have to counsel the patient thoroughly and properly, and if you have to sighting of the stoma, you will preoperatively you have to mark the sighting of the stoma where there will be colostomy sites. In our country, there is no stoma nurses or a stoma physician, but in the Western countries, there is a group of surgeons or physicians. They call stoma therapists. They counsel the patients before operation. In the preoperative region, they locate the site of the stoma. They advise the patient the stoma, what are the maintenance and what are the complications may occur in case of stoma, and if complication occurs, how they will deal with the stomas. So everything is taught before the operation to the patients. Another important thing is the correction of the anemia and electrolyte disturbance. Malignant patients are usually anemic, so you'll have to preoperatively have to correct the anemia, and if the patient is having an electrolyte imbalance, you will have to correct the electrolyte imbalance as well as. And cross matching of the blood, this procedure sometimes causes bleeding, and usually 1 or 2 units of blood should be kept at hand before you start the procedures. You have to apply the prophylactic antibiotics. It's very, very important to prevent infection. We always use prophylactic antibiotic. Prophylactic antibiotic means the uses of the antibiotic before infection has develops. We anticipate there will be infection, so we will apply antibiotic before infection has develops. So there is a policy, and in each hospital they have got separate policies of the antibiotic prophylaxis, what type of antibiotic, at what route, for how many periods. So you have to consider the issue of the giving prophylactic antibiotic during this surgery. Another important complications of this surgery is patient may develop pulmonary embolism. So this is a very dangerous complications after surgery. If a patient develops pulmonary embolism, that is a very, very detrimental condition for the patient. So to prevent pulmonary embolism to occur, we start usually the deep vein thrombosis prophylaxis. The source of the pulmonary embolus is the deep vein. So these patients, you must be very cautious to do deep vein thrombosis prophylaxis by using of the heparin. So this is the chemical method. Of course, there are some physical methods also by which you can do a deep vein thrombosis prophylaxis. So our aim is to not to develop deep vein thrombosis. And of course, before doing this procedure, insertion of a Foley catheter is a must. Combine, that is abdominal and perineal synchronous excision of the rectum. This operation is required in the lower third. If a tumor is involving the lower third of the rectum, in that case it is not possible to save the sphincter. It has the advantage for difficult tumors, the lower rectum, and 2 surgeons are operating from the abdominal and the perineal approach simultaneously. The site for the colostomy is in the left iliac fossa and should have been marked preoperatively by the stomach care nurse in consultation with the patients. If it has not been possible, it should be sited equidistant from the umbilicus and the left anterior superior iliac spine at the linea seminoris. Is about 2.5 centimeter above the spinal umbilical line. So this is the scientific site where to do a permanent colostomy. A circular piece of skin and fascia is about 3 centimeter diameter is excised. Rectus sheath and the muscle layers are split, and the peritoneum is divided, and a colostomy has been done. Radiotherapy. Regarding this radiotherapy, with modern techniques, some adenocarcinoma now respond to radiotherapy. Various control trials have been performed to investigate the effect of adjuvant radiotherapy given either pre or postoperatively. The overall result of this trial suggests that the provided and adequate doses is given, the neoadjuvant radiotherapy can reduce the incidence of local recurrence. However, long-term survival is not affected. So, if you administer neoadjuvant therapy, it is possible to reduce the local recurrence. After operation, this is a very important issue. Within 6 months or within 1 year, the patient came to us with the local recurrence. And if you go this policy, if you maintain this policy of neoadjuvant therapy, so a local recurrence has been reduced. So it is a normal practice. Before going to this operation, all patients should receive neoadjuvant radio or chemotherapy. Again, the chemotherapy, a variety of the drugs has been tried, both as an adjuvant therapy and as a treatment of the disseminated disease. The commonly used drug is the 5-fluorouracil. So 5-fluorouracil is the common drug we use as a chemotherapeutic agent for carcinoma of the rectum. Thank you very much. Thank you. Your next class is pediatrics.
Here is sir.